It's noon. Good afternoon, everyone. Thank you so much for all coming to Medicine Grand Rounds. Today is one of the lectureships from the Renal Division, is the Robert and Elaine Collins Lecture. The Collins family provided a very large endowment to the Renal Division under the leadership of Dr. Burrell that allows us really to pretty much continue the research and education mission, and more importantly, to invite great lecturers like we are very lucky to have today, that is Dr. X. Dr. X is the Darrell and Dorothy Ann Fanstel Professor of Medicine. He's the Chief of Renal at UCSD and Vice Chair for Clinical Affairs in the Department of Medicine. He did his undergrad at UCSD, graduated from med school at University of Chicago, and then went back west to do intern residency and fellowship at UCSF. After a very short tenure in San Francisco, he moved south to San Diego, where he became pretty much went up the ranks and currently is a professor of medicine. He has received numerous awards, including a member of the American Society of Clinical Investigation and the Scholl Mastery Distinguished Award from the National Kidney Foundation, has over 500 publications, is PI on approximately 7 NIH grants. He is a wonderful mentor, wonderful friend, and really a leader in our field. And we're lucky to have him as the Collins lecturer today. Thank you, Joe.
Making sure I'm audible first thing. So let me make sure I can bring up the slides. Do I have a clicker? Let's see here. Maybe if I could ask for help to bring up the slides. So firstly, I'd like to say a very warm thank you for the invitation and how incredibly honored I am to be here today to give this presentation. A special thank you to my host, Dr. Chanchol. I feel like the two of us grew up together a little bit in nephrology. I remember sharing conferences with you at ASN and sharing ideas even 15 years ago. So it's particularly nice to reconnect here. I wanted to begin by thanking the Collins family for the opportunity to visit as a visiting professor under their name. There's actually a story about the company that Dr. Collins started with his colleague, Dr. Bellows, and the name Kobe for the company that they started actually incorporates their two last names. And this was really the beginning of a lot of the dialysis equipment that we still use today. And so really an incredible gift to our field in medicine through a non-academic approach. And it was a really fun read to read their book and learn a little bit about his career and what he's done for our field. And so really honored to present today under their name and to have the opportunity to share ideas together. I wanted to also briefly give disclosures. I've worked with a number of companies on advisory boards, research support, as we've talked about. I'm also in leadership roles of KDIGO, which writes guidelines for care of kidney disease patients worldwide, including blood pressure guidelines. And I have a role with our National Society in the ASN. None of these are directly related to my talk, but of course, some of these companies do create medications that treat blood pressure. I'm not going to talk about medications today, but I did want you to be aware of those conflicts. And then to go ahead and get started. So today, for me, I think this talk is a bit of a departure and perhaps a bit of a risk. What I typically think about in my research sphere is in two areas. One is assessing bone disease in patients with kidney disease, particularly how do we mark bone turnover and treat bone disease in kidney patients. And then secondly, in a talk that I gave this morning to the renal division around interstitial fibrosis in the kidneys and ways that we can mark that non-invasively, either by biomarkers or by imaging. And so typically when I'm invited to give a presentation, it will be on one of these topics, and I'm not going to talk about this at all today. I'm going to instead give you my own personal insights into a story where I learned a great deal about my own approach to the practice of medicine through conducting a clinical trial. And I thought it might be most appropriate for a general medicine audience, as I think it has broader implications. So my goals for the talk first are to describe my own process for learning and understanding through conduct of a blood pressure trial. And this has really changed my own clinical approach to medicine beyond that, really in a way that may feel a little uncomfortable about being more aggressive in older and frailer patients. And then finally, if we have time, I'd like to discuss some practical ideas for blood pressure measurement that are relevant both at the individual patient level and at the healthcare level that might improve blood pressure management. So we'll see how that goes. Okay, so here's my outline. I'll start with 2 cases and we'll just get right into it here. So firstly, in 2010 or so, a mutual colleague of Dr. Chanchal's and I reached out to both of us and told us about a new blood pressure trial, the SPRINT trial, which perhaps many of you have heard of at previous conversations here, that was going to test intensive blood pressure lowering to a target of 120 versus 140. And the reason we were getting this call is they proposed to recruit about 30% of this large cohort in patients with chronic kidney disease. And so I was asked if I might serve as a site for recruiting and to guide the study in terms of CKD management, given that a large number of these patients were going to have chronic kidney disease. And I thought about this for a week or so and really thought about, was it going to be safe and ethical to treat patients to a blood pressure less than 120? And I wasn't so much worried about kidney disease patients as I was frail and older patients that might participate in this study. Because in my own clinical judgment, I really thought that being less aggressive in that setting might be better for patients in that setting. And again, my opinion about this has changed, and that's really what I want to focus on. But what I thought I knew about older patients was these principles here. Start low, go slow. Polypharmacy is a real problem. Patients obviously don't like taking pills. Almost all older people have hypertension, so is it really a disease? And at this time, guidelines had shifted quite a bit. It used to be a target of less than 140, and at this time in older patients, the target had moved to less than 150. It's confusing. So perhaps it's easier just to treat patients less aggressively, especially if patients agree. So this was truly where I was clinically at this time. And I'll give you 2 patients. The first is a 75-year-old female who's healthy generally, had a benign ovarian cyst removed 2 years ago, but otherwise no real medical history. She's active and walks 3 miles a day. She takes a multivitamin. She really does not like taking pills and doesn't want them, but will do so if it's necessary. And her biggest fear is dying in pain or having a stroke and then living with disability. And at the bottom, I have a little table that outlines her blood pressure over a series of years. And you can see that she was initially 157/70 and was advised to do diet and exercise. Came back over a year later, 148/65, and was told, no worries. The guidelines say less than 150 is fine for your age, you're doing fine. Another almost year goes by, she's 172/70. She's told again, diet, exercise, but come back in 6 months. Comes back 6 months later, 178/68. Please cut your salt, come back in 3 months. And then finally, 3 years after, she started on a low-dose amlodipine pill. We'll come back to her course. The second case is a 78-year-old man with Crohn's disease and hypertension. He has non-proteinuric CKD with a creatinine of 1.6. This was actually a patient that I'd cared for a couple of years, and he was interested in participating in the trial. So he met eligibility and was randomized to the intensive blood pressure target with a goal of less than 120. In the second bullet, you can see that I titrated up his antihypertensive medications. And at the last visit before this episode, his clinic blood pressure was 124/60, so he still wasn't quite at target. And then maybe a month later, he presented in the emergency room with 5 days of diarrhea. He was hypotensive, hyperkalemic, and had acute renal failure with a creatinine of 5.7. And perhaps the most memorable aspect of this case was the challenge from a really smart resident at UCSD who stopped me in the hallway and said, how could you ethically treat this patient to less than 120? Guidelines say less than 150, and look what's happened here. And I don't think it was, maybe it was intended, but it clearly felt like you have done this to this patient and you've caused this acute renal failure and you know better, and was this ethical what you've done? And when you're challenged by a colleague, particularly a smart learner who you respect, it really makes you step back and wonder. Okay, so hypertension, it's something that's quintessential to internal medicine. We all know a lot about this. It's been a treatable disease for over 50 years. I just want to remind you a little bit about the epidemiology and why I think it remains relevant and important today. So obviously extremely common, strongly linked with cardiovascular disease and particularly stroke, and is really, I think, a really nice example of preventive medicine disease because we have good treatments, they're cheap, they're effective. Of course, some of the drugs do have side effects. And I think treating blood pressure to lower levels is unquestionably beneficial in terms of preventing CVD and stroke. But this trial that I'm talking about today was really about how to treat and how aggressively and in whom. To remind you that the prevalence of hypertension is about the same as age. So by the time men and women are in their 70s, about 70% of patients have hypertension. So almost all of us will develop this as we age. And then I want to overlay two slides. One here is looking at the change in cardiovascular disease death rates over years over the x-axis on this slide here. And whether you look at men or women or different definitions of CVD, CHD, or stroke, we've made remarkable progress in reducing cardiovascular disease deaths in this country. And this is almost definitely multifactorial. People are smoking less, they're eating better, they're exercising more. But at the same time, I want to show you this slide, which are overlaid bell-shaped curves of blood pressure across different generations of NHANES, so different patients in cross-section. But you can see that this bell-shaped curve has definitely shifted to the left, right? So concurrent with these dramatic improvements in cardiovascular disease, we've also treated patients more aggressively, and on average in the population, blood pressure has gone down with time. And I think that that's part of the story. So then what's the right target? And here, observational data and clinical trial data can give you really different stories. So there are a myriad of papers such as this one. I could have chosen one of maybe 10 that are similar. This study here looked at older patients aged 85 or older, which is the focus of my talk today. And you can see this bell-shaped curve, which really centers around a blood pressure of about 165 and is adjusted for a number of things, as you can see down below. And if you took this as what to treat blood pressure to, you might argue that a blood pressure of 140 to 165 might be the best target. But these are observational data. Randomized trials data look quite different. So this is a meta-regression plot. So these are all different clinical trials that have tested more or less aggressive blood pressure lowering. The big dots are larger trials. The smaller dots are smaller trials. But the lesson from this study really is that regardless of where you start, the greater reductions in systolic blood pressure translated into greater CVD reduction. And so we have a challenge with the observational data versus the clinical trial data, where we're wondering what the right target is. One of the concerns about observational data is the following. If you look at patients with the lowest blood pressure in observational data, so this is the column on the left, you see certain patterns where patients who have lower blood pressure tend to be sickest, right? So whether you look at their age, their ability to do their own activities of daily living, their mini mental status exam, whether or not they have atrial fibrillation, the list goes on and on and on. The patients with the lowest blood pressure tend to have the most comorbidities. And when you have these measured, you can adjust for many of these, but you begin to wonder how well those are measured and how many other confounders aren't available that we can't adjust for in these models. And so it really makes you wonder if these U-shaped relationships are confounded, particularly when you realize that there are other U-shaped relationships for other things that we typically think lower is better, whether it's cholesterol, body weight, glucose, GFR. So that really led to the design and the conduct of the SPRINT trial. And again, what I'd like to do here is in one slide or two slides, summarize the main findings of the SPRINT trial, but then focus on the oldest and frailest subset, which is where I think I've learned the most. So briefly, the SPRINT trial was a multi-centered trial funded by the NIH, predominantly by the NHLBI. We recruited over 9,300 individuals with a mean age of 68 years. All of them were hypertensive, and largely for power reasons, because we needed enough CVD events. These were high risk for CVD event patients, so either known CVD or a high Framingham risk score, or CKD is defined as an eGFR less than 60. And while we targeted about 30% of patients with CKD, we managed to recruit just a bit less than that, 28%. They were randomized to these two blood pressure targets, less than 120 versus less than 140. There was a mean of 3.3 years of follow-up, and we excluded individuals with diabetes, severe proteinuria, or polycystic kidney disease. The primary composite outcome was a composite of CVD events. And there were a number of, I think, really important secondary outcomes, all-cause mortality, kidney outcomes with a complicated definition, which I'll not go over now. And then importantly, brain outcomes, so dementia and mild cognitive impairment. We did quite well with separation. You can see that the mean blood pressures changed quite quickly after randomization in this trial. The blood pressure was on average about 13 millimeters of mercury different across this time period. And to accomplish that, it required one more medication in the intensive arm on average. So it's in small print, but the standard arm was taking 1.9 medications on average versus the intensive arm was taking 3 medications on average. The main results of the study was a dramatic reduction in the risk of the composite cardiovascular events endpoint with a hazard ratio of 0.75, and really very similar results for all-cause mortality. And it was really the combination of those two endpoints that led the DSMB to stop us early in 2025. And it was thought, I presume to them and to all of us, that people would embrace more aggressive blood pressure lowering, which has not really translated as widely as I'd hoped it would. The number needed to treat in terms of absolute reductions was 61 individuals to prevent 1 cardiovascular event. And as I recall, it was about 90 to prevent 1 mortality event. And if we look at the different endpoints, again, very similar point estimates for both CVD and all-cause mortality. And perhaps referring back to our first patient, many older patients are worried about cognitive impairment, also a dramatic benefit in preventing mild cognitive impairment with more intensive blood pressure lowering. But certainly no free lunch, much higher risk of incident chronic kidney disease, higher risk of acute kidney injury events like our second patient, higher risk of hypotension, syncope, and interestingly, really no signal for injurious falls, but certainly a concern in the study nonetheless. So again, harking back to these observational data, which would have argued that in this population, we should maybe target 140 to 160. And then we look at the SPRINT trial, and what I'm going to show you next is what happened in participants that were older than 75 at the beginning of the study. The results here look very much like the overall study. You can see that the blood pressure targets were 134 in the standard arm and achieved 123 in the intensive arm. You can see that the point estimate for reductions in CVD were, if anything, stronger in this older cohort. There was also statistically significant benefit for mortality. And I list the main adverse events at the bottom. Now, some of these are not statistically significant here, but I think you'll see the same signals that we saw in the overall study. What's more important here, though, however, is that the absolute risk of adverse events was much higher. And so with the same relative risk reduction, the benefits in terms of number needed to treat was substantially lower. So rather than needing to treat 90 patients to prevent 1 mortality, it was 61. And rather than preventing, or rather than having to treat what is it here? To prevent one death, instead of treating 90, you'd only have to treat 41. And for CVD, it was 61 versus 27. So the absolute risk reduction was substantially higher here. One further step down the rabbit hole. Not all of these individuals were healthy, as you might expect. I remember participants coming in wheelchairs, having real comorbidity, having bypass surgeries. And while the trial was being conducted, we did a lot of work to develop an index for frailty. And this included things like how fast they walked, the number of comorbidities, the number of medications they were carrying. And we validated this frailty index through placement in nursing homes, falls, other endpoints that we could get to during the trial. And so we had a nice validated measure for who was frail and who was fit. When we stratified the older group into those that were less fit and frail, again, my hypothesis was that these patients would benefit less from intensive blood pressure lowering, at least for mortality, if not for CVD, when in fact that's not what we saw. If anything, the frailest patients had the same relative risk reduction, and if anything, in some instances, lower risk of CVD and death than those that were fit. Around the same time, there was another paper from the HIVET trial. Many of you may not remember HIVET, as it was primarily done in Europe, but these were 80-year-olds that were hypertensive that were randomized to a thiazide and an ARB. They also had a frailty index. And on the left side, as the frailty index number goes up, these are more frail patients. And in their randomized trial, again, targeting lower blood pressures, although not to 120, again, you see this signal where the individuals that seem to be the frailest seem to have the most benefit in terms of stroke prevention, cardiovascular events, and mortality. And again, this makes me uncomfortable because these are the patients that in my own practice I was most worried about being aggressive on in terms of lowering their blood pressure. So what about harms? Well, that's complicated. And I want to highlight what I think is really fascinating work from a young investigator named Simon Asher, who's out at UC Davis. He's a hospitalist, now funded on his K Award, and he's really interested in this concept of net benefit. So how do we balance the benefits from an intervention versus its harms? And how do we incorporate patient preferences to make sure that we're making the right decisions? He worked with us and published a nice paper in JAHA last year. But you can see that on the right side are the things that, that this trial was able to reduce. So things that we don't want, mortality, MIs, strokes. But on the right side are things that, that were at higher risk. So higher risk of injurious falls, higher risk of AKI, electrolyte abnormalities, and syncope. So how do we really balance this? So what he's done here is he's developed a model to predict the risk of adverse events, which you can do. Again, similarly to the frailty index, you can identify individuals that are more likely to have adverse events. It turns out to be the older and frailer patients who are also getting more benefit from CVD risk reduction. And if you can look at those that are at high risk of harms, so in the yellow here, as a whole, they generated more benefit. So they're at higher risk of adverse events and higher risk of CVD, but on balance, they were getting more benefit from intensive blood pressure control than those that were randomized to the less than 140 arm. In the box is a little grading scale, if you will, which is graded about how harm tolerant or adverse you might want to be. And this is how I might grade it. So death would give it a score of 1. I wouldn't want a stroke. I made that a 0.8. But having a fall or an electrolyte abnormality is not a big deal to me. So I'd put that at 0.1. But you can imagine how these could be gauged differently by different patients. So this is the harm tolerant group. What if we change this to those that are harm adverse on the right? So now something as simple as an electrolyte abnormality gets a scale of 0.5. So that's almost as bad as having an MI at 0.6 if death is 0.1. So this is really, I don't want medicines. I don't want to be treated aggressively. And even in this group, the vast majority of older patients that are at high risk of CVD and high risk of adverse events were getting substantial benefit from intensive blood pressure lowering, even if you weight against their wanting aggressive treatment for being harm averse. So to put numbers to this, so if you're harm tolerant the way I was, so there are two things happening: what's your harm tolerance and what's your risk. So if you're harm tolerant and you're low risk, perhaps that's me, you would get a 1.8% net benefit from intensive blood pressure lowering. But if you're high risk for adverse events and you're harm tolerant, that number was 5.3, so there was more benefit. Perhaps most striking is the harm adverse row. So if you're harm adverse and you're high risk, you're still getting substantial benefit, a 2% benefit with intensive blood pressure lowering. So again, trying to balance the intervention, the absolute risk, and the tolerance to risk. More recently, Simon and one of his young mentees, who's a young nephrologist in San Francisco, put the same idea to the frail and older patients. And what I pulled here is comparing patients that are aged less than 75 versus those older than 75. And if we maybe take, if we take MI, which is kind of in the middle, you can see that those that are older in the green have more benefit in terms of MI prevention with intensive blood pressure lowering. But on the right, if we take kidney harms or injurious falls, they're also at higher risk of these adverse events. And so how do we balance those? We definitely want to avoid these on the right, but how do we balance these? In the same way, you can stratify by fit, less fit, and frail, and the idea is the same here. Again, patients that are frail in the kind of peach color are getting more benefit in terms of MI prevention, but they're also at higher risk of these adverse events. So if I take the older patients here, and again, I look at those that are harm tolerant on the left, that's okay. There's a lot of benefit. Essentially, almost everybody who's older than 75 and harm tolerant is getting benefit. But if we go to the right to those that are harm adverse, right? So if you're harm adverse and younger, you're getting benefit. 75% are getting net benefit. But if you're older than 75, despite being harm averse, 97% of these individuals treated with intensive blood pressure control were getting benefit. And it was the same way if you were frail or taking more medications. So how do we fit this with our clinical experience where we're afraid to be aggressive in old patients with a lot of comorbidities? Because my clinical experience is that I don't want to do this. I'm afraid to do this. So maybe I can best describe this through two examples, and just think as a clinician of how you feel if you're this patient's doctor. Okay. So a 79-year-old female who's hypertensive and otherwise healthy, her blood pressure is 146/70. She's on amlodipine. Based on recent recommendations, you titrate up her blood pressure medications. You bring her to a blood pressure of 123/60. She now presents with a hip fracture, and in the emergency room, her blood pressure is in the 90 to 105 range. How would you feel? I think you probably feel like I did with my AKI patient. Darn, I think I caused this lady's hip fracture, and I feel bad about that. How about this patient? 82-year-old patient in your care for 5 years, recently admitted with a stroke, new aphasia, and difficulty walking. You look back at your records, and at your last visit 6 months ago, the blood pressure was 143. 3 months ago, it was 148. He's on antihypertensive patients. You encouraged him about diet and exercise, but you didn't change his medications. Did you cause his stroke? I don't think any of us would stop and worry about that. The blood pressure is 140. We do this all the time. Bad things happen. And yet the data suggests we contributed, right? This patient should have been treated to less than 120. We need clinical trials. And the reason is because we can count the adverse events and the CVD events that we're trying to prevent. Without getting CVD events and looking at them in two arms, we'll never be able to see the events that we're preventing, right? And so what I really learned from this that's really changed the way I practice medicine is the following. When we provide an intervention and it contributes to an adverse event, it's natural for us to feel badly, maybe embarrassed, because of the realization that we're doing exactly what we promised we wouldn't do. We've caused harm. The problem with prevention is that when we do something that's the right thing to prevent an endpoint, we never see that event. And we never know if we help that patient or the next patient or none of them. Right? As I said, we need clinical trials with two groups that carefully count both the benefits and the risks so that we can understand these things, engage them. And sometimes the results are surprising. But I think overall, when we do something and something bad happens, it's natural for us to want to be less aggressive. And yet, when we do our best, sometimes we're doing things and bad things happen. So I think there's a bias here where we see adverse events and we don't see the benefits, and it biases us to want to be less aggressive with our patients. This is what I learned from a blood pressure trial, and yet you can imagine other parallels, whether to anticoagulate a patient or not, whether to be more or less aggressive with their diabetes control, whether or not to send them to surgery, whether or not to use aggressive chemotherapy. And I don't have all the answers about the right level of being aggressive without clinical trials in these data, but it's really had me rethink my approach to the older patient for common diseases. A couple of comments about blood pressure measurement. So in line with this, I guess I am encouraging you to think about being more aggressive with blood pressure lowering for the most of your patients if they're agreeable. And if we do that, if we're pushing blood pressures closer to 120, we really need to know what the real blood pressure is, not what the machine told us or what the MA told us as the patient was running in from the car in a rush and frustrated. And so I thought I'd make a few points about blood pressure measurement, both on the individual patient level and perhaps an opportunity at the healthcare level. So, in these clinical trials, we're using AHA protocolized blood pressure, which means the right size cuff, feet on the floor, sitting there for 5 minutes, getting 3 blood pressures, taking an average. I don't think most of us do this in clinic. But critical to this is the 5 minutes of rest. And I can tell you that during this trial, every day I would get called from primary care that, Mr. Smith is here. He's in your trial. The blood pressure is 165. What do you want us to do? And we'd say, well, bring him down. We'd sit him there for 5 minutes and the blood pressure would be, 138 on a good quality measurement. And that becomes really important if we're targeting 120 and we get a number of 120, but the real blood pressure is 100, right? Thankfully, there's lots of these machines that give us a way to program them. So you can just press the button and walk away for 8 minutes. It'll sit there for 5 minutes and run through it 3 times. And so we did this in our hypertension clinic. And I'll just give you an example patient on the left. You can see their blood pressure. Not only was it higher on average, but much more variable before we did this for 3 clinic visits. And then when you do this in clinic, suddenly you get, on average, lower blood pressures, but also much more narrow. And so it's a sign that you're getting more accurate blood pressure measurements. Paul Draws, one of our colleagues who's very interested in hypertension at the University of Minnesota, took the opportunity in the sprint blood pressure trial to tie a subset of about 2,000 or so patients that were getting their care through the VA system to the CPRS data. So he could compare their blood pressure by AHA protocolized blood pressure in the trial to what they were getting in clinical practice. And on average, what he noticed was that the blood pressure in the clinic was about 10 millimeters of mercury higher than by AHA protocol in the trial. But I think more importantly was the limits of agreement. So that was plus or minus 35 millimeters of mercury. To say it another way, it's so noisy, it's hard to know what their blood pressure is unless we give them 5 minutes of rest and really do a good quality blood pressure measurement. So casual BPs are highly variable, about 10 points higher, but you can't simply subtract 10 because you don't know what the individual patient's blood pressure will be if you do that. Okay, so from the healthcare system, I had an interesting conversation. So my interest was, let's get better blood pressure control in our health system overall. It'll help us. Our quality team came to me and said, boy, we really need help. You know, the MedStar ratings are an important metric for us. We get paid by how well we do on the MedStar rating. And it turned out blood pressure was highly weighted here. So to give you an idea, discussing breast cancer screening, if you could document that in your primary care clinic, they got 1 point for that. If you talk about urinary incontinence, they get 1 point. But if you achieved a blood pressure less than 140/90, they got 3 points. And they were not doing well in blood pressure control in our primary care appointments. And so the question was, give us help. Like, how do we do this better? As I said, our target rate was only at 60%. And so I said, well, you know, if you do 5 minutes of rest and get 3 blood pressures, so a total of 8 minutes, you're going to lower the blood pressure readings by 10 millimeters of mercury. And there was huge pushback. You know, we don't have time for that. There's no room for that. You know, and so we had to work through it. We had to get new machines. We went through a system by which the MA would set it up and press the button, and the physicians would need to write down the blood pressure and hand it to them on the way out. We made the point that how often, you know, do you go to the doctor and do you wait 8 minutes before you're seen by somebody? That's usable time if we use it well. And so this is what happened over a 12-month period. This is where we started this protocol, and the number is the proportion of patients reaching target of less than 140/90. And so we had quite dramatic improvement in our blood pressure readings. Now, I'll be clear, I'm not sure we improved anyone's blood pressure, right? But at least we're getting better data, which is the first step. And it's a way perhaps to align incentives from the health system and their reimbursement and their desire to do high quality care to get high quality data for us when we're seeing our individual patients. Okay, finally, I want to come back to our 2 cases. So the first was the 75-year-old woman who was healthy and had lack of inertia, in my view, around her blood pressure. And this is just to tell you about this one hitting home. So this is actually my mom. This occurred during the trial, and as a reminder to put your money where your mouth is. So I got her a new primary care doc. We were more aggressive with her blood pressure. She's on 2 medications now. She feels great. Her blood pressure is around 120, 121. I do give her strict instructions to avoid NSAIDs, and she knows it's okay to hold these medications if she's not eating well. So sick day precautions are really important when you're aggressive, but I feel like I'm doing the right thing for her. And this is somebody who doesn't like risks and doesn't like medicines, but as I said, I've really learned from this experience. The second case was a 78-year-old patient with Crohn's disease who showed up with acute renal failure in the setting of diarrhea, and I was kindly accused for being unethical. So this patient was diagnosed with C. diff colitis and pre-renal azotemia. His meds were held. He was given IV fluids, and his creatinine went down to 1.6 about 3 days later. Over 2 months, we reinitiated his blood pressure meds towards a blood pressure goal of less than 120. And he developed a pleural effusion from metastatic cancer of unknown primary, didn't want to be treated, and passed away. And, you know, again, we'll never know if I improved his cognitive function, if I prevented a stroke or a CVD. And it's really the paradox of preventive medicine. So there we are. Thank you. Happy to take any questions.
Thank you very much. That was great and very thought-provoking. So I guess my question is, if we are looking at being more aggressive for older patients, did anybody take into account their support system or, like you said, sick day rules, things like that are pretty important if you're going to be more aggressive for people. So it would make sense that maybe in the clinical trials where there is more support and more monitoring of those types of things, that's why we see more benefit, is because they also have, kind of a safety net a little bit. But when we look at it in real world settings, if somebody has a very supportive family or son who's a cardiologist or, a nephrologist or something like that, they're going to be paying closer attention. But somebody who has no support,
Yeah.
they might be the ones more prone to falling or having acute renal failure or things like that.
Sure. No doubt. No doubt. And, the art of this is individualizing, right? And we need to. I'm not, I don't know what to tell you in terms of blood pressure control in the nursing home setting. And of course, you have to make decisions, in conjunction with your patients and taking the whole person together. So I completely agree with you. On the other hand, individualizing just doesn't give us a guide forward for what we should do for the average patient, right? And again, this was a big eye opener for me because I really thought this was not the right thing for all patients. And it's not until you see the numbers and you look at it, in patients who are harm averse, old, frail, and you're seeing these benefits that you have to step back and say, well, why is this not the same as my clinical experience? And I think it really is that we don't see the benefits. And so again, in your patient in front of you without a support system, I don't want to venture to what the right thing is, and things could be different, but I do think we're being less aggressive than we should overall.
Hi, I'm a primary care doctor. Thank you so much for your talk. We've had a similar experience implementing the 5-minute how to accurately check blood pressures. One of the ways that we are approaching this is increasing reliance on home ambulatory blood pressures. And I was wondering if you could speak to your experience in terms of limitations and also potential benefits of the increasing data we can receive from patients at home.
Sure. This can be anecdotal. There's one clinical trial of blood pressure control that used out of clinic blood pressures, and it was in pediatrics, and they used ABPM. So it's not going to be relevant to our older patients. So I put a lot of weight into home blood pressures. And the other thing that I've noticed with our protocolized 8-minute blood pressure protocol in our hypertension clinic is where I used to spend all my time of, why are you telling me it's 140 at home and it's always 165 here? That now when I'm getting my 8-minute blood pressure reading, it's so much more correlated to what they're telling me at home. So I don't have data, but in my personal practice, I put a lot of weight on what patients are getting at home.
Joe, do you want to comment a little bit about also the effects of intensive blood pressure control in the elderly and cognitive function?
Sure,
Yeah,
sure.
as-
So yeah, in my view, that may have been the most important outcome of the whole trial. This was a major effort. Give you a personal anecdote. I had one coordinator early on in the trial, and she got ill and left. And so I had to learn how to do these cognitive tests as I was hiring a new coordinator. They were intense. Like, we had to video record, they were reviewed, we were told you didn't quite ask this question right, we had to retrain. So there was a lot of energy in put in to make sure that we got really good cognitive data. And again, maybe living with cognitive impairment is worse than dying for some. So the fact that this intervention improved cognitive impairment, I think, is incredibly important. We learned yesterday, Michelle and I, that there are long-term follow-up data from this trial now 7 years out that looks like there's a legacy effect. So even though they were treated intensively for only 3 years, there's persistent benefit in cognition even 7 years out. And so I think it's a very, very important outcome.
Thank you, Joe, for a great presentation. Appreciate your visit. Thank you.